You're watching CTOM TV. Knowledge is power.
And now, Alex, you've prepared some information for us about diagnostic imaging.
Right, yes.
So, do you have a plan for how you'd like to go through that? You
yes,
do?
I usually have a plan, as you know me.
Yeah.
May not be the best plan, but I do have a plan.
All right. So what is your plan? How would you like to go
So I'd
ahead?
like to just have a brief overview of what imaging is, go through some of the modalities, and then talk about, advances in those modalities, and then use some key examples of how imaging really can be used to help in treatment.
Okay. And this is one of the things we talked about last week when we talked about questions to ask your doctor, how to advocate for yourself to make sure you're getting the best cancer care. One of the common objections that we hear is that a certain type of imaging, it's not necessary. It's not going to change your treatment
We're going to address
plan.
That issue
We're going to
today.
come to that? Okay,
yes,
excellent.
We are.
Good,
yes.
Good. Okay, so what is imaging?
So the first thing, how is imaging, what is imaging? How is imaging used?
Okay.
So why do we do imaging? Well, there's two reasons we do imaging. We do it, number one, to detect the initial tumor, the primary, and then that gives us some idea of staging.
Okay, and I just, for the folks at home, because I just really find this, my brain is really slow. Imaging is?
Seeing the tumor.
Seeing the tumor. So tests that allow you, so it's not like a blood test, it's a test that allows you to visually see what's going on inside the body. Okay, so common forms of imaging?
We'll get to that.
Okay.
Let's start with my plan.
Okay.
So how is imaging used? Imaging is used to detect the initial tumor, as in staging. And then it's also used to monitor patients, and that's what we call standard serial imaging. And so this monitors the progression of a patient or their response to treatment. So these are the two ways. So initially to diagnose a primary and get an idea of what type of cancer you have based on the primary, and then and also give you a staging. And then number two, to monitor you through the progress of your disease in response to drugs, or whether you're progressing or not. And so the second part of this, obviously the detection of the initial tumor is fairly straightforward. But the second part of this, the serial imaging, basically follows what's called the RECIST criteria. And the RECIST criteria is how you respond to certain drugs. And so it's broken down into 4 different classifications. The first one is a complete response, and that's when you have a disappearance of all the target lesions. Then you have what's called a partial response, and so that's at least a 30% decrease in the sum of the largest diameter of all of the target lesions that they're measuring. And then there's stable disease, and so that's neither shrinkage nor growth. And then, of course, there's progressive disease, which is at least a 20% increase in the size of the target lesion. Now, of course, all of these go with the size of the lesion. So that is one of the things with RECIST and serial imaging, is it looks at changes in the size of the tumor in response to disease. So with the assumption that a shrinkage of a lump or tumor is going to be a response to a drug, and then expansion is going to be obviously progression. RECIST criteria is used obviously to define whether you're responding to a treatment or not. So those 4 responses dictate, whether your treatment is working or not. Obviously.
So you said, I was busy scratching notes down, and did you say complete response means your tumors are all gone?
Yes.
Okay, so it's not that they're all shrinking, it's that they're all gone. And then
target lesion.
Okay.
So the target lesion they're looking at.
Okay. And then the partial is they're at least 30% smaller.
Yes.
Stable is they haven't grown or decreased.
Right.
And progression is they're 30% bigger?
20%.
20% bigger.
At least 20%.
At least 20%.
Size, yes.
Okay. So that's
it's all based on size.
Okay. And that's what's called the RECIST criteria.
Yes.
Okay.
This is what doctors use.
Okay.
Okay. So now we're going to cover the types of imaging.
Okay.
So the types of imaging used to determine these RECIST responses are based on ultrasound, which uses sound waves. Then there's X-rays, which obviously use ionizing radiation. Now, X-rays use a single point, and what they do is they will send a beam of X-ray radiation, or ionizing radiation from one point, and it will go through a specific part of your body, and then a collector will pick it up on the opposite side. And what they do is they look at different tissue densities by how much radiation is absorbed through the path of the beam.
Mm.
And so the theory is that if you have a lump that is a different density than the surrounding tissue, then that's potentially cancer. But it's also benign lump or calcium deposit or many different factors it could be.
Right.
So it doesn't, standard imaging doesn't tell you whether you have a tumor. It just tells you have a lump of different tissue density.
Mm-hmm.
So X-rays are the main one that are used often because they're cheap and they're easy to use, and you can manipulate the X-ray beam to where you want to use it. Then you have CT, which is computed tomography. And this is where you go in a hollow tube, and it's very similar to an X-ray, but the difference is that you have this rotating detector and sending mechanism that blasts a beam through your body and detects it, and they rotate around you together. So they get a 360-degree image of your entire body. Mm-hmm. So whereas an X-ray is just a single beam going through at one point and picked up, this is a full 360-degree process of your body. And if you see these things without the covers on them, they're quite noisy, but I saw a picture or a video of one of them with the cover, and this mechanism is spinning around so fast you can barely see it. It was quite incredible. It's just like zipping around this person. Mm. So an MRI uses magnetic resonance imaging. So what this does is it uses a powerful magnet and radio waves to do the same sort of imaging, but it does it without radiation. So what happens is it creates this magnetic field around your body, and then it pulses radio waves through your body to the areas being pictured. And the radio waves, basically what they do is they resonate the tissues, and specifically they focus on the water content of the tissues, because different tissues have different water contents. Mm. And so that's how it detects the differences in the tissue densities, is through water. Mm-hmm. Now, there's also a new type of MRI that has been recently developed by someone we know, Dr. Rajatawala. It's called Pre-Nouveau. I haven't had a lot of chance to look over it, but it's a very interesting new technology that combines certain aspects of MRI with a better way of determining whether a cell is cancerous or not. Mm-hmm. And I think they've been running it for about 2 years now, a year and a half, and I think they're getting fairly good results. I think their sensitivity and specificity is pretty good. Mm-hmm. And then there's PET, positron emission tomography, and this is where you combine a radioactive isotope that is attached to a sugar, and you drink this, and then any tumor cell in your body, because it's highly metabolic and actively growing, is going to drink up a large amount of this sugar radioactive isotope. Mm. And then they give you a CT scan, and anywhere in your body that has this radioactive isotope is going to light up like a Christmas tree. So we've talked about PET in great detail. You did a wonderful article on PET that's downloadable from our website. We've discussed PET CTs on Cancer Guy. And I think, it really is the technology that has changed cancer treatment.
Because it doesn't just look at a difference in density and indicate that there's something there. It clearly indicates whether something is metabolic.
It bypasses the need for the RECIST criteria. Mm. You don't need to do serial imaging. I mean, you do to see whether the drug's working or not, but for diagnostics, mm-hmm. you can tell right away whether a lump is a tumor or not, mm-hmm. from a PET CT.
Well, and even now, you can use liquid biopsies to tell whether your treatment is working, so you don't have to do many PET CTs.
Right. So commonly we hear from our patients that they ask their doctor for a PET-CT, and the doctor says it will not change the way they're going to treat the cancer. Obviously, that's very much misinformed.
It's outdated.
Outdated. There's a multitude of different ways that PET-CT can provide you with benefits.
And the cancer agency in British Columbia, which is a province in which we live, for example, how long ago was that they put that statistic out?
Quite a long time.
Was it? Yeah. So for quite a few years, cancer agency, at least in BC and almost certainly others around the globe, have actively stated that in over 80% of circumstances where a patient gets a PET-CT scan, the initial treatment protocol is changed.
Mm-hmm.
So if your oncologist is telling you there's no need for a PET-CT, we already know everything we need to know about your cancer, it's not going to change the diagnosis, remind them of that statistic, that over 80% of the time, your treatment plan will change. 87.5% of the time. Yes. Your treatment plan will be modified based on the data from this scan, which means that only 13-ish% of the time is your treatment plan accurate without it.
Yes. So some of the benefits of PET-CT and how it will change your treatment is that it provides real-time data. So that means it tells you right then and there whether that lump you have is cancerous or not. And it doesn't require that you come back over various months to see if that lump is going to grow or shrink or stay the same.
Yeah.
Which is commonly used to determine whether you have cancer. So it provides biological data. It tells you how aggressive each individual tumor is. And this is important for a variety of reasons. Number one, if you have a more aggressive tumor that's easily removable, and then you have another tumor that's larger and not likely to metastasize because it is mostly necrotic, then obviously you want any sort of treatment such as surgery or radiation therapy to focus on the aggressive tumor that may be smaller and easily accessible versus the larger tumor. You can't do that with the other modes of imaging. It doesn't really tell you how aggressive the tumor is.
Or it doesn't even tell you it's a tumor.
It doesn't even tell you it's a tumor, exactly. And then importantly, if you're going to have a biopsy, you want to know that you're going to have a high tumor content in that biopsy. And a PET-CT prior to the biopsy will let you know that. And then importantly, especially if you're going in for a biopsy that's invasive and a difficult area to reach. And because PET-CT provides you with the serum uptake value of the radioactive nucleotide, what it does for individual tumors, it can tell you which tumors are responding to a certain combination of drugs and which tumors are not. So it allows you to tailor your targeted therapies and your treatments to specific protocols.
Right. So if your oncologist is not using targeted therapies because they haven't done any genetic testing for you, you're going to be missing out entirely on that. You're going to be missing out entirely on these benefits, right? Because they're
So, while I think most people in cancer care and research across the globe understand how important a PET-CT is. It's not that often that we do get doctors who don't understand it. I think maybe access and cost is more of a problem in Canada. But if a doctor who you're speaking to tells you that they'll get turned down for a PET-CT, then obviously they understand the importance of it. If they tell you it's not going to benefit you, you need to get a new doctor right off the bat. That's someone you probably don't want to be treated by. So more importantly, PET-CT can alter treatment decisions in a very specific and unique way that a lot of people don't understand these days. And so one of the ways is I'm going to give you an example using prostate cancer. So prostate cancer, as we all know, has something called PSA, prostate-specific antigen. But what many prostate cancers also have is they have this prostate-specific membrane antigen, and that's called PSMA. And this is on a large percentage of prostate cancer cells. It's not on all prostate cancer cells, and it can come and go. But the importance of it is there's a type of PET-CT that actually targets that molecule. And so it's able to detect prostate cancer cells throughout the body. So normal FDG PET-CT can only detect prostate cancer cells if they're very aggressive and they've metastasized. And it doesn't detect prostate cancers very well. So this PSMA is an advance in that it can detect prostate cancer cells that are not very aggressive or that are just growing and metastasizing throughout the body. And it will tell you, this is a prostate-based tumor based on this PSMA expression. So what's important about that is not only does it tell you and give you a tool for working with prostate cancers, but there's this whole area of technology for treating prostate cancers that are based on targeting the PSMA molecule, this antigen on the outside of most prostate cancer cells. And so there's a variety of different approaches to this, and we're going to go over a few of those because they're getting amazing results now. There's some really great technologies, and the concept of this is referred to as theranostics. It's really big in Australia. There's some research in Germany. In Canada, there's some research, even locally.
So does theranostics preclude you're using a PET-CT scan, you're just using it in a newer way?
You're using a PET-CT scan for treatment.
Okay.
And I'll explain how that works.
Oh, cool.
So once again, this PSMA is the target. And so for a long time, what happened is once we knew that there was this PSMA target, we knew that we could actually use the technology from PET-CT, the radionucleotides, and bind them to an antibody, and then put them in an antibody for this PSMA, and then inject them into the body, much like a PET-CT. So this technology came from PET-CT, and then came from PET-CT imaging of PSMA. And so they inject this molecule into you, and anywhere that you have a tumor that has this PSMA molecule on it, this antigen on it, this antibody will find it, bind onto it, and deliver a drug payload. So that was the first technology.
Wow.
So PSMA targeted antibodies. And so this is very similar to PET-CT.
Wow.
Now, the technology has changed quite a bit since then. So originally they used antibodies, but the problem with the antibodies is they bind onto these cells, and they could bind onto other cells and so on. And it had high side effects.
Oh, okay.
So a lot of patients had problems with this. So since then, they've created a new technology called small molecule technology. And this is using basically the same isotope or the same sort of technology that the PETs use for the imaging. So, originally they thought, well, let's have an antibody because that will bind onto these tumor cells and kill them. But now they realize they can use the same technology as the PET if they use a powerful radiation isotope. And so what the technology is now is they have these small molecules that will bind to the PSMA target, and they can attach a variety of different payloads to kill it. So rather than an antibody, they're using small molecules.
So again, layperson question here. Just remind me or go over again, how is that different from the theranostics you were talking about earlier from a side effects perspective?
I was just about to go into
Oh,
that.
sorry.
So this new technology that uses small molecule technology allows for quicker clearance. So in other words, the antibodies are hard to get rid of by the body.
Right.
So the quicker clearance results in less damage to normal tissue because the radioisotope is removed from the body. So as you know, with PET-CT, you get the injection of the radioisotope, and then after a few hours, 4, 5, 6 hours, it's gone. It's out of your body. So this is borrowed from that and uses that technology rather than having an antibody that will stay in the body for a long period of time. So the radiation comes in and gets cleared out of the body much quicker.
Cool.
And so most of the focus has been on something called lutetium-177. And this is what we call a beta emitter. So it's a type of radiation. And so one of the drugs is called PSMA or PSMA 617. And this is a small molecule radioligand therapy. And so recently it was shown in heavily advanced prostate cancer patients. All of these are used in really advanced prostate cancers, metastatic castration-resistant prostate cancers that really have no chance of responding to anything else. And in these patients, they got a PSA decline of over 80%. 50% was observed in more than 64% of the patients.
Wow.
Including 44 patients with PSA decline of over 80%, which is huge. And then out of this group of patients, 56% had a partial response or a complete response. So the trial's still going through. So this is the beta emitter, lutetium-177, using PSMA small molecule targeting, which is the same as the PETCT PSMA testing.
Wow.
So another drug called Lu-PSMA I&T got a 80% PSA decrease with more than 50% noted in these patients. So, you know, these drugs are working quite well, quite quickly.
No doubt.
Now, lutetium works well, and it can, you know, work for a while, but obviously the patients are going to have their prostate cancer return after some time. And so because of this, a new company has developed, excuse me, has looked at a new one. Actually, sorry, I need to back up the bus a little bit. I forgot one. There's also a drug called Bind-014, and it's had a bit of a sordid history. So it is a PSMA small molecule technology borrowed from PET, but they combine it with a docetaxel, which is normally used to treat prostate cancer. So I just covered two drugs that use lutetium-177 as a payload to kill the cancers with this PSMA targeting. And so Bind-014 doesn't use radiation, it uses chemotherapy. So it is a targeted chemotherapy, and I think this is an area of research that is really expanding. So in this particular drug, this Bind-014, the prostate-specific, the PSA response rate was, you know, greater than 50% in at least 30% of patients. And there is measurable disease response in at least 32% of patients. Now, these are patients that would not respond to any drug that we have.
Wow.
And they don't have any treatment options. So sorry, I missed that. I wanted to start with that. So there was initially the combination to this PSMA targeting that we borrowed from PSMA PET-CT, has been used to treat cancers using this concept of theranostics. And the payload has been either a chemotherapy drug such as docetaxel or lutetium-177, which is a beta emitter radiation. Now there's another one called actinium-225. And the reason they're looking at actinium-225 is because it's a type of radiation called an alpha emitter. And basically this technology came from the Russian Secret Service. So alpha emitters are very, very powerful emitters of radiation, but they don't go far. So they don't penetrate thick layers of skin, for example. So the Russian spies are able to go poison their targets and carry this on them without it hurting them. Whereas if they used a beta emitter, they would get some radiation exposure themselves because it has it travels further. So the alpha emitter doesn't travel as far, but it offers a much higher dose of radiation. It just doesn't travel as far. So it's going to have less side effects.
So it's got to be positioned properly in your body or delivered properly.
We have this PSMA that's going to position it right on the tumor.
Right where it needs to be.
So we don't have to worry about positioning.
Right.
That's not the issue here.
Wow.
So the issue with the lutetium is it's going to kill the cells around the tumor as well because it's a beta emitter. Whereas the alpha emitter is only going to kill the tumor itself. because it's only bound to the tumor.
Mm.
So it's got a shorter range, as I mentioned, and it reduces, effects on salivary glands and also on blood cells, because blood cells are obviously going to be surrounding the tumors, and they're going to get damaged by any sort of treatment that targets the area around a tumor. It's going to kill your blood cells too, and you don't want that. And also, this is being touted as a drug that could potentially be used once patients become resistant to, or not a drug, a treatment that is going to work for patients who become resistant to lutetium-177.
Mm. This is the actinium-225 you're talking about there?
Yes.
Mm-hmm.
So it's like the second generation of PSMA targeting drugs.
Wow.
Yeah.
And given that really just this last month, a whole bunch, North American-wide clinical trial for that type of PET-CT, that PSMA, just wrapped up, and it's now being put through to the FDA for approval for mass distribution. So we should be seeing lots of this.
Yeah, I think some of it is already approved, isn't it?
Well,
I believe it's being used now. I mean, you can definitely get these treatments. You can get all of these drugs.
Well, that's wonderful.
Yeah, that's why we have data for them.
Sure. I'm just aware from my own experience this last couple of weeks of trying to find a place where somebody could go to get this particular service. And
oh, do you mean the testing?
Mm-hmm.
Oh, yes. Okay, so sorry. Can you remind me? Can you repeat that?
That's
very exciting. Yes, I forgot you were looking into that.
I was simply saying that they're a big international clinical trial looking at PSMA testing, the validity, the benefit, and all of that stuff.
PET-CT PSMA.
Yes, it literally just wrapped up and again has been put forth for approval. So almost certainly what that means is that your oncologist, wherever you live in North America, will soon at least be able to find a place where you can get that test.
Yes.
Which is good.
Well, we can access it privately, and we've been accessing it in Canada via the kind of clinical trial approach.
Yes, hence I mentioned they just wrapped up.
Right, right. Okay, sorry, I missed that. So why, let's get back to this importance of this test.
Yes.
Why is it important?
That's a trick question.
It is a trick question. It's funny because we sent a patient recently for this testing. It was available for the patient, and the doctor said, well, it's not going to make a difference in how we treat you. And so, that really bothered me. So I wanted to educate the doctor on why it's beneficial to understand why you should be using this PSMA-based testing.
For prostate cancer patients.
Right. But why is it important to use this PET-CT for these patients? That's a good question. Well,
if I took any notes of any significance earlier, that fundamentally it's because without this type of test, it's really hard to see into the prostate. It's hard to kind of follow those particular molecules that have, right? Am I on the right track? No.
Well, this section has focused on PET-CT and treatment decisions.
Yes. Hint, hint. There's a hint in there somewhere.
Treatment decisions.
Yes. Well,
okay, I'll cut to the chase.
Thank you for Pete's
So, how are you going to know if any of these new drugs, such as Bind-04, lutetium-177, and this actinium-225, are going to work?
Well,
you get a PSMA PET-CT, and any tumor that lights up to that is going to respond to these drugs.
That makes perfect sense.
So that is why you need to get this PSMA PET-CT.
Right. If you have,
it will tell you whether these drugs are going to work for you or not.
Right. Yes. And if they do, what you're saying is in some cases there's like an 80% response or decline.
Well, the problem with these trials is they, didn't necessarily determine whether these patients had PSMA expression on their tumors before they sent them into the trial. Not every patient is going to have that. Not every tumor is going to have that. So by having one of these PET-CTs, then you can determine whether this whole area of theranostics is going to be beneficial for you or not. Right. And then you could choose through the different drugs.
Right.
But without that initial PSMA PET-CT, you're not going to know if this treatment is going to be good for you or not.
Yeah. And
So that was my response to the doctor. He said,
Right.
it's not going to change our treatment decisions. Well, yes, it will change your treatment decisions.
Right.
It will decide whether a class of drugs is going to work for you, or a
Right.
class of technologies is going to work for you or not.
Right. And that's really it, is that the more of these highly specialized, nice slurping there,
Thank you.
the more of these highly specialized diagnostics that you have, the more accurate your treatment can be.
Exactly.
And again, I think so many people are still operating from and understandably, because if you're out there living your life, you're not thinking about advances in cancer care and what's possible in the way that someone like Alex might be. But so often I think people still think in terms of chemo or radiation, or there's like two choices for treatment. As we were saying in the top of the hour, there's hundreds and hundreds of treatment options. It just depends on what's driving your cancer. So the more thorough your diagnosis, the more possible options there are. And now you're saying not only can PET-CT, this awesome imaging tool, be used to more accurately diagnose prostate cancer, a location and all this.
And determine whether theranostics treatments are going to benefit you or not.
That's right. It can determine that and then be used in that protocol of theranostics to deliver the treatment.
Totally.
Yeah, that's pretty cool.
It is, yes.
Right on.
Amazing new technology.
Yeah. So we're going to be seeing lots more PET-CT machines, that's for sure.
Hopefully.
Yeah. In the U.S., there are literally thousands of those machines. Other countries have many, many as well. Canada has 35.
Wow.
But the U.S., just south of us, and there are private PET-CT clinics in Canada. So if you're a Canadian watching this and you want to make sure that you get a more accurate diagnosis from an imaging perspective, that can be arranged privately as well. If you're in the U.S., your oncologist may very well have already ordered one for you. They're almost commonplace, aren't they?
They are, yes, definitely.
Yeah. Well, that's really cool. So this imaging technology is being used not just to make sure you have a more accurate diagnosis, but actually for treatment delivery.
Totally.
Wow, that's really neat.
Yeah.
So back to that question that we had earlier about, when will there be a kind of a cure-all for cancer? Again, kind of what we're seeing time and time again is the cure is going to become more and more personalized, but technologies are consistently evolving to give you that option of a more personalized diagnosis.
Exactly.
Yeah,
that's a great way of putting it.
Thank you for watching CTOM TV. Subscribe below and stay informed.